All right, everybody, welcome. Welcome to the Sports Medicine Research Rundown. With tonight's guest is Dr. Mendez. Dr. Mendez is an orthopedic surgeon at Northwell Health and New York Orthopedics who grew up in Richmond, Virginia. He went on to attend the University of Virginia, where he graduated with a dual bachelor's in physics and economics. From there, he got his MD degree at Emory University School of Medicine, and then he went on to do residency at the University of Miami, where he did probably a lot of trauma at Jackson Memorial Hospital. I would think we can ask him about that. But then he did a fellowship with us at NISMAT at Northwell Health. And it is my distinct pleasure to have an outstanding orthopedic surgeon that does a ton of ACLs and shoulder arthroscopies on tonight to talk about concussions. Yes, I begged him to talk about concussions because I didn't have a doctor that I knew very well to talk about concussions, but he's been given the residents and the fellows the concussion lecture for the last 10 years. He does a great job, and he is so knowledgeable. I said that we got to beg him to do it. So thank you so much, Dr. Mendez, for coming on tonight.
It's my pleasure, Tim. Thanks for the introduction. I'm happy to be here. It's a topic that I've grown into and have come to love. So
Before we go into that topic, where do you see patients when you in New York City or anywhere else for that matter?
we have two offices in Manhattan, one in the West Village on 12th and 7th Avenue, one on the Upper East Side on between 3rd and Lexington Avenue on 74th. And then I have an office in Brooklyn Heights where I see patients 2 or 3 days a week, and I'm in Staten Island actually half day a week seeing
Oh, yeah.
patients.
All right. At this point in time, do you cover any teams or not? No.
I do. I'm the head team physician for Queens College. So I
All
take
right.
care of all their sports, coordinate their care with some of their primary care docs, and then I do some recreational soccer teams that we cover, but
Oh, good.
just for fun.
That's great. And with those teams, do you ever see concussion?
We do. I see a fair amount. The Queens College is, I think the incidence of concussions there is not as high as some other schools because they don't have a football program, they don't have ice hockey.
Mm-hmm.
So we mainly see them in the soccer players or sometimes in the basketball players, but we get around 10 a year or so from all sports.
Excellent. What is the concussion? Can you tell us what a concussion is and what happens
Uh,
when
yeah,
someone gets a concussion?
sure. It's on the spectrum of a traumatic brain injury. It's really on the left side of the spectrum, so something like a mild traumatic brain injury, and it's really more complex than many people realize, especially when we talk about what's going on inside the brain. What it is, it's a functional impairment in the brain, and there's a cascade of events that occurs. So a blow or an impact to the head causes a disruption in the brain, and that disruption can sort of be thought of as an electrical or electrochemical storm where your neurons or your brain cells start firing abnormally. They release excessive amounts of what are called neurotransmitters, and this creates sort of an energy crisis. The brain works to try to correct and restore balance, and that's really the sort of the 50-yard line view of what's going on when there's a
Mm-hmm.
concussion. What this means is that once you have an injury to the brain or an impulsive force, everything your brain is trying to do is trying to restore a state of homeostasis. And the symptoms that we see, whether the sleep disruptions, the mood, loss of memory, exercise intolerance, are all secondary to that attempt to restore homeostasis.
Okay. And to restore homeostasis and decrease, is there an inflammation process within the skull that happens, or is it what's going on there?
Yeah, so on a biochemical level, what's happening is that we mentioned a neurotransmitter. So what happens is there's release of an excitatory neurotransmitter called glutamate.
Mm-hmm.
Primarily, what happens is that glutamate triggers this flood of ions. So the human body, instead of like electrons, we use charged charged ions. So potassium and calcium are the main ones in concussion. So what happens is potassium rushes out of the cell, calcium rushes in, and then we have what's called ATP, which is the energy store of the cell, and adenosine triphosphate. We activate these ATP pumps in our brain, and those ATP pumps, they try to restore balance. And what they're trying to do is pump potassium back into the cell to restore balance. But that consumes a ton of energy. So you get this mismatch of energy demand At the same time, you have a reduced energy supply because of the buildup of acid and also because the calcium that we discussed earlier can be toxic to mitochondria. So you're not able to produce as much energy to stabilize the cell.
Yeah, I remember when you were presenting, maybe 5 years ago, 7 years ago, they were working on some medicines or drug treatments to mitigate that. Did that happen? Do they use those? Did that work out, or
Um,
what's going on with drug treatment for that?
Yeah, so in sport concussion, no. When
Okay.
we talk about drug treatments, there have been some drugs that we can take from the military. So from the experience in Iraq with blast injuries,
Mm-hmm.
um, and there have been some that have been used in studies, but they're not clinically available or used widely.
Excellent, thank you. And you don't necessarily need. So we see if we're watching NFL football, we see so many receivers going over the middle. Then the back of their head hits the turf. They're down. They have a concussion. But you don't necessarily need to have a blow of the head to have a concussion. Correct? You mentioned to me once that you can get hit in the jaw and have a concussion. Is that?
Yeah,
Can you tell us
so
about that?
I think the best way to think about it is that there's really two forces that we're talking about, or two accelerations on the brain. One is a linear acceleration, and you can think of that as getting punched with a jab and your head going straight back. The
Mm-hmm.
other the other is rotational acceleration, and that's you can think of that as getting hit in the jaw with a hook and your head spinning around. So the brain can tolerate linear forces relatively well because it's cushioned by cerebrospinal fluid, and there's sort of a forward to backward motion. When there's a rotational acceleration, rotational force, what happens is that there are these shearing forces between different layers or different densities in the brain, and that's thought to be much more dangerous. Of course, neither of these happen in isolation. They're sort of there's a vector of each in any real world event. But the other thing is a blow to the body can cause a whiplash mechanism, like we're talking about, like a car accident, where that
Mm-hmm.
force is transmitted, through your cervical spine into the head, creating an acceleration, which can lead, to high G forces on the skull.
Right. Is that why for those concussions that are caused by the high G forces, the helmet doesn't work because you don't have a direct blow of the helmet. So you have just that sort of whiplash kind of acceleration within the skull. Is that why that doesn't work?
Yeah, and I think it's it might not be as protective, but certainly there may be some protective benefit from
Hmm.
when the deceleration happens, when the skull or the helmet hits the ground or hits the astroturf or whatever. But yes, in generally yes, that's why you can't fully prevent concussions from better protective equipment.
So once you're on the sidelines and you see the mechanism of injury, and I know that when I'm on the sidelines, I can tell when a kid's coming off and he's not clear, he's foggy. Um, can the signs and symptoms be latent, or do they usually occur immediately, or how does that
Yeah.
work?
So we look for the first thing to do, and I think that everybody should be aware of is we look for the red flag. So any focal neurological deficit
Hmm.
is a red flag. So I mean those are things that we don't even once you see somebody with a focal neurological deficit, you assess them. Anybody who's having neck pain, seizures, obviously loss of consciousness, vomiting and worsening headaches, those they need to be closely monitored and potentially taken off the field, taken out of the uh, to an emergency room or to a higher level of care. But in general, when we're evaluating somebody that doesn't have a red flag, I usually start, and I think it's recommended to usually start with a simple assessment. You can ask them orientation questions. What's your name? Where are we? What quarter are we? What score is it? Who are we playing? Those are really the first line of sort of interaction with the athlete with a suspected concussion.
Good. Rob, any questions at this point in time, or Donis for that matter? Anybody?
Not at this point, actually, no.
All right.
I do have a question real quick
Yeah,
on that topic of
sure.
quick diagnosis. There was some talk about having like sideline diagnostic tests with like saliva, blood markers.
Yeah.
Uh,
So there's a few that are being studied. So what are the biomarkers have been studied, and they're actually being used in trauma. Again, there's one called GFAP, which is a glial fibrillary acidic protein. That there's something called the iStat, which is, I believe, a medical device that can test for your GFAP. And it's really used to look if somebody has an elevated GFAP, then they don't get a CT scan. There's studies going on some of these, and there's a few other biomarkers. I think one's called NFL, but it stands for neurofilament light, and one is like a ubiquitin protein. I don't remember the exact name. Um, there's been a lot of studies on them, but none of them that have clinically gotten to the sideline in practice yet, except for in the ER with that iStat test to try to. And the reason that they're able to do that is, one of the issues if somebody has a TBI, um, you know, traditionally, if you go to the ER, you get a CT scan. The issue with CT scans, as we're appreciating more and more and more, especially the brain, is they do cancer a lifetime potential oncologic risk, right? So uh, it can be estimated that for every head CT, there's a zero point 0.3 or whatever it is chance of percent chance of cancer. So if we're able to do an intervention to
Mhm.
limit CT scans on people that maybe don't need them, that's a benefit.
Good.
when we talk,
Thank you.
oops, sorry. When we talk about concussions, as far as like CT scans itself, imaging, not necessarily how important, right? Compared to
Right.
we can still have a concussion without a brain scan, a
Bleed.
normal
Yeah.
scan, correct?
Right. Yeah, exactly. So CT scans, only if they're really focal neurological deficits, only if somebody has a GC Glasgow Coma scale of, less than 15, or they're deteriorating, or they're vomiting, or they have something where you're looking for something like a subdural hematoma, or, even worse, like an epidural hematoma. The problem is that if you take a kid to the ER, a lot of times they're gonna get scanned, or at least traditionally they will, right? So
Yeah.
that's why I think as anybody covering the sideline, you really want to be careful before you send a kid straight to the ER, and do it, for the right reason, not just reflexively, right? We don't want to be reflexively CTing everybody, every
Mhm.
every kid who gets hit in the head.
True. And what about the old fable or adage, or just don't let your son sleep if he had a concussion when he gets home? What can you
Yeah, I mean,
shed some light on
so
that?
I mean, it depends, right? So yeah, that's actually the opposite right now, but um, we want them to sleep. You want to encourage sleep. But the reason that is that there's something called an epidural hematoma,
Yep.
which is deadly, right? You'll see news stories about somebody get punched in the face and he was fine, and then he goes to sleep and he never wakes up, and that's due to rapid bleeding, in the brain, which increases pressure, and you can cause a. I'm not a neurosurgeon, but my understanding is you can cause a herniation, and then the brainstem herniates and they stop breathing and they die. So that's where that comes from. It's extremely rare. You want to monitor somebody who has a concussion, obviously for that, but telling them not to sleep for, extended periods of time is the wrong advice. It's actually the opposite. Sleep disturbances is are one of the hallmark of symptoms of post-concussive post-concussive symptoms. So we really want to encourage good sleep habits. We want to limit screen time
Hmm.
to help recovery.
Well, we talked about the physical symptoms. What about those cognitive symptoms? That
Yeah.
are often described that we look for as athlete trainers and physical therapists. Can we talk about that
Yes.
first?
Yeah, so I mean that happens later. So just to touch on it, right
Hmm.
after on the sideline, just some other tests. There's something called the SCAT-6, which is a sideline concussion assessment tool, and after we screen for the concussion on the sideline with tests like that, there's the office assessment. So the office assessment is really looking at some of those other the mood symptoms, sleep disturbances, difficulty with exercise tolerance, um, differency with saccadic eye movements, which is one of the hallmarks, having difficulty with balance,
Hmm.
focusing issues, and that's typically a lot of that's mostly done in sort of the subacute phase in management. And I think as we're getting more and more sort of aware of these subacute symptoms, there are strategies for management in the office and in the subacute setting that are specifically looking for ways to treat these sort of clusters of symptoms. So I mentioned the saccadic eye movements, like the vestibular ocular symptoms. There's the VOMS, which is a vestibular ocular motor screen, looking for deficiencies and convergence. And if those are found, things like vestibular therapy can help and can help treat them, and it is associated with faster return to sport. Um, so for other symptoms like headaches, they can be treated with medications. Uh, Disturbances can be treated with better sleep hygiene, obviously limiting screen time. Um, there's, perhaps short-term melatonin or other sleep aids on a very, very short scale.
I know that at our high school we used the impact testing for neurocognitive too. We did preseason testing on every single athlete that played freshman JV and varsity athlete that played sports, whether it was contact or non-contact, and then we were able to provide the post-concussion testing after when it was warranted by the physician. So it's very
Yeah,
useful.
I mean, yeah, Impact's it's a great tool. I mean, it's been around, I think, for 10 years now. I think it was approved as a by the FDA as a medical device, and it's a computerized test, as as you talked about.
Yeah.
The one there's two issues with it that come up, I guess, and one is the cost associated with it
Yes.
for it's very expensive. And the other is, like you said, you really need the normative data. There's a normative database, but it's validated with a baseline score. It's much higher, sensitivity with a baseline score. One of the things that's always brought up with the impact is there are kids that have, if they have a second concussion this season, their scores always get a lot better, even though they've had a second concussion, because there's a gaming effect to the test. The more times you take it, the better you get at it.
Right. Good. In terms of treatment, I know that rest is beneficial. Can too much rest be harmful?
Yeah, so historically there was what was considered to be a cocoon therapy, right? The idea is that we would put these kids, even when I was in residency and training, it was thought that you put the kids in a dark room, they don't go to school, they rest their brain, they don't look at TV, they sit there by themselves and just sort of with the lights off, or in a cage. That's been shown to be associated with prolonged symptom, worse return to sport, and there's some theories. So one of the theories is that after there's a sort of a psychological sort of a nocebo effect, right? We all know the placebo effect. So you give a treatment, and even if it's not helpful, people think that they're getting better. There's potentially a nocebo or a negative placebo effect to put in, especially an adolescent, in a cocoon therapy that makes them anxious, it makes them deconditioned, that makes them think that they uh, have a worse problem that they have. They get, sort of in this like doom loop. After really the current treatment algorithm is an initial period of rest, and then what we discuss is sub-threshold exercise. So that's exercise to a threshold that does not induce symptoms. Um, so gentle aerobic exercise,
Okay.
and that probably improves blood flow to the brain. It helps regulate the autonomic nervous. All the beneficial things of exercise, right, can help with this
Absolutely.
as
And that
well.
and that, and that's step one for our return to sport progression at our high school that we developed. Just having them walk around the track and get their heart rate up from their resting heart rate. So before we go further into the exercise prescription, Rob or Donis, do you have any questions on or any caveats or pearls that you guys have on the rest and returning them to school?
Yeah, I know. I mean, really, 0 to 2 out of 10 is one of those early, right? Let him get some activity, just kind of grade him with
Right.
that,
Yes.
and then the thought process. Also, we're talking about behind treatment wise, but how much do you do? Like, I guess you'll differentiate cervical, ocular, vestibular. Do you send out PT for that? Do you go to the trainers? Who's doing that kind of training?
So
Great
I have a
question.
yeah. So we have I have a I have a primary care sports medicine doctor. But I will if they're Um, so he does most of the referrals for that, especially if there's like
Hmm.
a vestibular thing. He'll do a VOMS. I think he'll if there's an issue, the trainer will do like a Buffalo treadmill test to see what their
Hmm.
threshold is to sort of establish a baseline of how much they can run and everything.
Right. I know there's a whole component, manual therapist. I mean, the cervical spine, it relates to headaches, right? So how
Yeah.
much of
Yeah,
that? It's
yeah,
a whole big, trigeminal nucleus type of
yeah.
reaction to it. So yeah, it's kind of an interesting population because it could, like, is it the eyes? Is it vestibular? Is it, more convergence issues? Because it's one of those more complicated.
And we have there's there's a few people a year we'll send to a neurologist if they just have persistent symptoms.
Right. Taking your athlete through the return to exercise, return to sport progression, you go from that sort of that light physical activity to light aerobic activity, getting the heart rate up, and then you'll put them into practice, or you'll have non-contact and contact, then return to game. Is that sort of your progression too, similar to
Well,
ours?
yeah, I think, the important thing is that they have to really pass through every one of the phases
Right.
and be asymptomatic, right? So, and that's where whether it's the trainer or the coach or depending on where you are, they really need to be monitored very closely in every one of if every one of their phases of a return to play progression. Um, and making sure that they're able, to hit the milestones safely, right, without having increased headache or feeling dizzy or return of their symptoms that they had post concussion, immediately post concussion. But yes, it's sort of light aerobic exercise, sport specific, non-contact, full contact, return to play. I think that's
What about what about medical clearance for these folks? We all know about the blue tent in the NFL, right?
yeah. So that's they have an NFL has like a non-affiliated neurological consultant that, started after the Tua debacle
Yep.
last year. And the idea, the whole Blue 10 idea is that you're away from the field, or not away from the field, away from the cameras, and there's not pressure, or at least there's less pressure on the people making the decisions that if they're in front of the cameras. So the idea is to have someone who does not have skin in the game as to whether this player is going back in the field, and the decisions being made away from the public eye.
Excellent. I think one of the most important things is protection, and how do we? No, I'm sorry, prevention. How do we prevent concussions from occurring? And there's been some theories that are thrown out there. I know one thing that I've read is that rule changes really helped lower concussions in ice hockey and in football. No checking in youth hockey really helped decrease concussions. But in football, do you think that the whole targeting thing and not lowering your head has really helped decrease concussions? I mean, I see more concussions than ever now.
Yeah, in high school football and professional football, I think a
Upper
few
ball.
things. So I think the rule change thing has been in the past 20 years. This all started with Chris Nowinski, and I think Chris Nowinski's deserves a ton of credit for what he's accomplished with a few other people, with Bob Cantu and all these people. But I think overall, as a society, the rule changes in sports and the have lower concussions, but they may not be teaching children when they start heading the ball or start hitting in ice hockey how to do so appropriately. So there can
Hmm.
be rule changes, but there also needs to be technique instruction as for when you start hitting, how to hit appropriately and how to play the sport appropriately to protect yourself.
Absolutely.
So I think in NFL football, there's certainly been a decrease in concussions with some of the rule changes on kickbacks. some of the targeting. I'm not sure if in youth football it is translated as much. I'm not sure if tackling, I think there probably could be better emphasis on which we've seen from rugby, right? So conditioning
Yes.
programs, teaching children how to tackle appropriately in rugby. We have data showing that that's lower the incidence of concussions in rugby.
Do those do those helmet covers help? You know?
Yeah, so I mean, helmets got I think protective equipment certainly has a role. I don't think the data bears out that there has been a proven benefit yet.
Mhm.
The NFL every year tests every helmet. The NFL Players Association tests every helmet, and they if a helmet is below a certain threshold of acceptable in their biomechanical test, it's banned from the NFL.
Okay.
So whether that has limited concussions, it certainly limits accelerations, linear rotational accelerations, but I don't think that's borne out as it's not that has not been demonstrated to translate to a lower incidence of concussions. Helmet covers, which I know we're going to get into in a second, but the NFL got big 3 years, I think, during practice and during the preseason with these helmet covers, and you saw the first two games of the season, all the linemen wearing these helmet guards, these guardian caps, and they published an article saying that they had a 50% reduction in concussion from having them wear them in practice and in the first two preseason games. So maybe they help. I don't know if there's any concrete conclusive evidence yet that they
Mhm.
reduce concussions. So.
Mouthpieces. How about mouthpieces? Whether it's football, hockey, wrestling, or basketball, do mouthpieces help prevent concussions, doctor?
Again, I think the data it certainly prevents jaw trauma,
And tooth injuries, yeah.
tooth injuries. You can definitively say that. Uh, Maybe in some types of blows, it helps uh,
Mhm.
lower transmissive forces to the brain, but overall, there's not a lot of conclusive evidence that it overall lowers the incidence of concussions across all sport.
Okay. What did help lower concussions, though, I know this from college football, is that the Ivy Leagues don't practice with contact practice anymore during the season, and that did help lower concussions. I read.
Yes, that's correct. Yeah, yeah, the Ivy Leagues have, they had a kickback rule before the NFL, I think in 2014 or 2015, which lowered their concussions dramatically in their football on their football teams. Um, and again, the limiting contact during practice, because if you look at the burden of head impacts for a football player, the vast majority of them are, something like 80 or 90% of them occur in practice and not in games. So
Mhm.
if you can lower that overall burden, and again, the issue is that there's no one blow, right? There's no like threshold as like at this acceleration you're gonna have a concussion, at this acceleration you're not. It's possible there's a cumulative effect of having multiple blows over a season, which may predispose you to a higher risk of concussion. I mean, this is certainly multivariate analysis. So I think
Okay.
limiting those impacts in practice certainly plays a role. But then again, it's not a zero-sum game. Perhaps they're not tackling. If you're not teaching tackling, it might increase your risk.
Right. If my son had concussion in week 2 of the ice hockey season, and now we're 10 weeks down the road of the season, is there a more likelihood chance that he'll have another concussion because he had that one early, or no?
How old is your son?
He's a fetus. I don't
He
have a
shouldn't
son.
be. He should. He shouldn't be playing that. No, no. I'm just. So most adolescents take about a month to recover.
Okay,
Yeah, the data will point to that they do have a higher incidence of a second
they
concussion.
do. Oh, okay.
There,
Uh,
there's a few studies that look at that, and that's that there's a higher incidence.
I was talking about Rob Shapiro's son.
Mhm. That's that's only baseball. You don't have to worry. He'll be good.
Um, any questions, Donis or Rob, before we get, or from the audience before we get into just a little bit about the article? The article was more for more for the pictures than it was for the actual article, but we'll talk about it in a second.
I have a question on a little bit of the preventative side. So back when I used to work with the football team, there was a big focus in the strength and conditioning to work on neck strengthening in order to prevent injuries. Any thoughts on where that came? Because I haven't really heard much about that.
Yeah.
And then I have another question after.
So a lot of that came from boxing, I think originally, like in like the 70s, and there was all this big push that the boxers, the if they talk about like a glass jaw, right? So the Mike Tyson, there's like a famous video of him like doing these crazy neck exercises on his, which if I did, I'd probably be quadriplegic. But he had this huge neck, and the idea that he was able to withstand any forces to his head. Um, so I think historically a lot of the neck stuff came from boxing. There is a device. There's a few devices actually, which are neck training devices out there. One is called, I think, the Iron Neck, and there's a few other neck devices. And the idea is that you may be able to withstand some of that whiplash by using these devices. I think it conceptually makes a little bit of sense. I have not seen any data that it does that a neck training regimen in the preseason for a football team is preventing concussions for them.
Also, one of the newer things that I've seen lately that I guess is taking some traction is the Q collar, where I've seen a bunch of players wearing that, either in like college sports and even NFL.
What is
Any
it?
So Q collar is a device that they put around their neck and is meant to allow blood flow into the brain or the head. So it kind of the point is that if you encourage enough blood flow, and it's similar to like BFR uh, conceptually, where you get a lot of blood into the brain, and that helps to kind of cushion or protect the brain from getting injured because it limits some of the flow of the blood out, so it keeps basically your head kind of over covered. I probably need to do a little bit more research on that, but that was the general gist that I got.
Yeah, I've only looked at it a little bit. I think there's a few studies. I don't know enough about it to speak about it intelligently.
All right. There's another question that came up. It said that they found use of optokinetic videos tends to stabilize gaze stability which helps in their recovery. Any thoughts on that? Optokinetic videos.
Yeah, I think certainly if they're having a deficiency in their VOMs, that certainly could be a treatment strategy that would help.
Next question is there ever a scenario where you would recommend an athlete to retire from their sport based on number of concussions or severity of concussion?
Absolutely. And it really depends. So I think the perfect example, just it depends on what level, if they're high school, college, collegiate, or professional. Certainly somebody like Tua, who's had multiple concussions, is at a higher risk. I think historically the issue, at least in the NFL, were that the NFL was perhaps minimizing the risk of concussions to players so that there was not, informed consent, and there were players were maybe being lied to and told that concussions aren't a big deal. They're not going to cause any problems later in life. They're not going to have a higher risk of dementia or movement disorders, not even to get into CTE. But I think the data's in the open. So if somebody wants to do it, I think to do a dangerous job and play in the NFL and it's part of their career, as long as they're not getting lied to, they have free will to do it. So we can certainly recommend, as long as they're being prevented with the data, they can make their own choices, right? I think in high school and college, certainly if this goes back to 80 years of sports history with Dr. Quigley at Harvard, who came up with the three strike rule, and after three concussions in a season, 70 years ago, you were done for playing football that season. I think that holds, sort of should still hold true in this day and age.
So another question that came in, I think kind of follows this up pretty well, is with people who've suffered post-concussion syndrome greater than a year, what are their chances of kind of returning to a prior level of function or normality?
I think it depends on what their post-concussion syndrome is. If they're having exercise intolerance a year out from the concussion, it's going to be difficult to get them to return to sport, I would imagine, at the same level. So I think it depends as you know what severity of true if they're just a little foggy and they feel like they can't perform as well in school, which we see sometimes with some of the college athletes, that they just, you know, they say they need more time, or they start to have need a tutor. You know, they still end up playing, but they still have still have some lingering symptoms, self-reported.
We circulated this article that Geraldine Martins and their co-authors put out, and it was sort of a re-examination of the sixth annual consensus statement on concussion in sports medicine, and this was published last year in BJSM. And what it did, it was it got a bunch of experts together, and they came up with some questions, and they did 10 systematic reviews and panel voting, and what they found was they were able to make some recommendations on the previous consensus statement. What I found very interesting about this article is that the average recovery times had been updated. The average recovery time for return to sport now is 20 days across all ages, and for return to learn to school, it's 8 days. But they go on to say there is a lack of information for children between the ages of 5 to 12 years old, and concussions in Paralympic athletes, and also in females. There's not a good body of knowledge in those patient populations. But they did make some good recommendations. They came up with that's how we came up with there used to be just the SCAT. Now there's the SCAT-6. There's the SCAT-6 for the SCAT-6 for children, and there's also the Sport Concussion Office Assessment Tool for in the office. So there's a lot of good things that came out of this article, but there are limitations, and we're making progress as a profession. Is there anything that you guys got that you wanted to highlight on this article, or did that kind of cover it?
Yeah, I mean, I think the refining of the you know the SCAT gets refined every 5 or 6 years. You know, we're now at the SCAT 6, but I think the office assessment, you know, and I think the meeting in 2022, the concussion sport group meeting in 2022, you know, really paved the way for these pathways. Like we talk about some of the vestibular ocular symptoms, the VOMs, and sort of looking at these subgroups of symptoms post concussion and ways to sort of targeted therapy to treat those, which I think for me has been sort of the biggest change since in the past 7 or 8 years.
Right. Donis or Rob, do you get a lot of patient referrals to your practices for concussion treatment? I mean, I don't know what I would do. What were you guys? I strengthen the neck. I do some balance training. I'm not so sure I know what I would emphasize. I don't do any vestibular training. I'm not trained in that to do foam and dome and those sort of therapeutic interventions. What do you guys do in your practice?
And the component, you know, is it more vestibular or is it more optic, you know, type of
Okay.
thing? Is it coming from inner ear? Might do some, and then the idea of the cervical component of it, I think, is big. If there is a headachy component, the manual therapy
Yes.
side of me towards that, and
Excellent
then
point.
getting in that, like anybody else who has like a motor control issue with the neck, we start doing a deep core, like stuff you were talking about, getting a deep cervical flexors to activate. A lot of times they just, they have that whole big sympathetic response. You have all those extensor muscles just kick in that are in that pattern. So we kind of try to break that pattern through kind of either reflex stuff or mobilization to activate the neck core, so to speak.
Excellent.
We had one of our clinicians that was doing like a pseudo study on treating concussion. She did a talk on the effects of manual therapy for those type of return to sport concussion. So she was doing like a whole routine of manual therapy techniques just to help kind of relax some of that tension that can happen from post-concussive syndrome.
Good. I'm gonna finish by going around the room and say, what's one thing that you would like every parent or athlete trainer or athlete to know? For me, it's if you have a head trauma and your headache keeps getting worse and worse and worse, go to the ER. That's my number one red flag. What is each of yours?
Yeah, I would make sure. I mean, I like that one the best, but I like the idea that let's figure out where it's, is it more ocular, vestibular, or cervical? So we don't just treat it as a concussion. There's so many different, put in the right category, so to speak, to kind of help progression.
I mean, for me, as an ATC, the one thing that I pretty much kind of recommend or stuck by was if they were suspected of having a concussion, I'm more apt to keep them out than letting them go back in, because you never know. It might be like a low level event that then could be worse later on from a second impact scenario. So I'd rather be safe than sorry in that standpoint.
Yeah.
There's physicians in Dr. Mendez's practice that will argue with you that you can have a headache from lots of things,
Right.
and if you're lucky enough to see the impact, yeah, then hey, you keep them out. But what if you didn't see? What if you were on the sidelines examining someone's knee when that happened? I mean, we don't have spotters in high school and college like the NFL, so.
Yeah, so there's still the concussion assessment you do on the
Yeah.
sideline. So that's what I'm using to determine, hey, does this person have concussive like syndrome, not just a
Right.
simple plain headache.
Excellent.
So that's what I would gear it towards. Like, hey, I'm seeing something here. You're better off not getting back in there before we do some further assessment.
Right. And Dr. Mendez, you've been on the sidelines with me for high school football games, and you get the last say. So what's your say?
So
Yeah,
it's,
go.
I think, and it's something I've told you before, Tim. I think,
Yes.
one of the issues with if you're a doc covering a game, and you don't intimately know the players like the coach or the especially in middle school, high school football,
Mhm.
knowledge of the player, knowledge of the player's psychology is extremely helpful with these kids. So if you know the kid, you've been with them, you know how they play, their anxiety level, you have a much better sort of insight into their mentality. And it's if you see something wrong, you sort of can pick it up a lot easier than a doctor that's just in the silence. So even though the doctors sometimes have the final say, I think it's up to the trainer or the whoever's with the team more often to really impart on that doctor. Listen, that kid, something's not right. I know he tested fine.
Yeah.
I think you need to sort of pull rank sometimes if something doesn't sound right.
That was awesome. Wow, I can't believe we spent 45 minutes talking about concussion. Us four. I'm so happy I had you. Thank you for coming on. Really appreciate it.
Thank you. It was a lot of fun.
All right. With that, we'll see you next time on the Sports Medicine Research Rundown.